Boy, I think MRI has been one of the big changes over the past 5 years. And the first place that MRI really makes a difference is in studying men who've had a previous prostate biopsy, and that biopsy is negative. And then over time, their PSA goes up or something changes, and we think there's a continuing concern for prostate cancer. Now we routinely do an MRI before we do a repeat biopsy. And if we see regions that are suspicious for high-grade prostate cancer, we adjust the biopsy to make sure we hit those regions. And that's called targeted biopsy. And that very much improves the outcome of repeat prostate biopsy. So we've known that, and it's been in our guidelines for more than 5 years. And what's happening is the radiologists and urologists are getting more comfortable with the newer MRI technology. And now we're wondering, gee, if I have a man and we're going to recommend a prostate biopsy based on a PSA or family history or rectal exam, shouldn't we do an MRI prior to similarly improve the performance of that biopsy? And I think many of our programs that are using MRI more liberally are wondering whether we can improve the performance of the initial prostate biopsy by doing an MRI. And that's an area of controversy, not yet in the guidelines. The big controversy is if we do that, we're going to increase costs of that screening episode. And is that justified by the marginal improvement in diagnostics? And that's the subject of a number of clinical trials. It was the subject of the whole session this morning, a debate between Professor Emberton and Dr. Pedrosa about where is MRI moving. And I think one of the places it's likely moving is earlier, meaning for the initial prostate biopsy.